Welcome to the Menopause and Cancer podcast, and welcome to this special mini-series of hormone replacement therapy after breast cancer, also called HRT or MHT, menopause hormone therapy, for those who've had a history of breast cancer. I'm very well aware that this is an emotive and controversial subject for several reasons, which we'll get into. But as the host, as Danny Bennington, who's hosted the Menopause and Cancer podcast for over 2 years now, we've gone out with weekly episodes. And as the founder of the Menopause and Cancer not-for-profit organization, I know how many people want to know more about it. It's very much a hush-hush, almost a taboo subject. Many people don't dare to even ask about it. They feel they have to do this behind closed doors. And so I want to bring it all out into the open. I don't mind to host this conversation. And I hope that together we can explore this subject a lot better. I'm also really, really grateful for so many amazing experts to join me on this podcast mini-series. Today, I'm going to be joined by Dr. Leila Agrawal, who is a medical oncologist. Then for the next episode, we're going to be joined by Professor Richard Simcock. He's a medical oncologist and also Macmillan's medical advisor. We're also going to be joined by patients and doctors who are taking HRT after breast cancer and prescribing HRT after breast cancer. And I can bring to you lots and lots of patient examples and their thought processes too. Now, before I'm going to introduce Dr. Leila Agrawal properly to you for today's episode, let's talk about why this is an emotive conversation. I really want to take my time with this here. So we're talking about risks and benefits, right? There are potential benefits to the use of HRT to alleviate your menopausal symptoms, to help with your bones, but also to significantly improve quality of life. And then, of course, people worry about the risks. So there is concern that HRT might increase the risk of breast cancer coming back, a recurrence. And this risk needs to be carefully balanced against the benefits. And of course, this is a complex decision patients and doctors need to make together. Let's talk about the emotional impact, and let's talk about patient anxiety. Women who've had a breast cancer diagnosis, me, myself included, often live with ongoing fear of recurrence. And so the thought of taking HRT could potentially increase that anxiety even more so. If that is you at the moment, this might not be a great conversation for you to tune into at the moment, and you might want to park it and come back to it at another time. However, if you are interested in exploring this because of your quality of life, maybe because of your long-term health benefits that HRT can give you, let's talk about it now. The severe menopausal symptoms you might be experiencing without HRT can be debilitating, and it can make the decision to avoid HRT in the future emotionally really challenging. For so many of you that I have been speaking to, you've had to stop your HRT when you were first diagnosed. If that HRT was really helpful, this might be a real grief process that you're going through now. And you might be younger, really curious about how you can help and bulletproof your future and long-term health. And that's why the conversation might be really interesting for you. Of course, we have different views here. So many medical professionals and researchers have different opinions on the safety and viability of HRT after breast cancer. And this leads to confusion and frustration for patients seeking clear guidance. And that brings me to medicalized medicine and to making sure you start to understand what are your true benefits to your true risks, because no breast cancers are the same. Some of you watching this mini-series might just be going through your active cancer treatment, and others might be 20 years on. You might have had different types of breast cancer, different treatment, diagnosed at different stages. And so there is no one-size-fits-all guidance at all. All we can do is really try and understand where we're coming from, where is this dilemma, and how do we move forward, most importantly. And let's not forget to make some ethical and practical considerations as well. Patients must be fully informed, I believe, about the potential risks and benefits for you. And yes, this requires really sensitive communication from healthcare providers. And this process can be fraught with emotional challenges. Of course, it can be. We're all human. We're all navigating this to the best of our abilities. And yeah, I think that really sums up some of the intricacies of this topic. For today's podcast, I'm so honored to be talking to Dr. Leila Agrawal, who is a US-based medical oncologist and haematologist, and she specializes in treating breast cancer patients. She's also involved in research and clinical trials, and she really strives to get to know every patient and learn what is important for them and their lives, from their families to their goals, and how that plays into important decisions about their health. It's a fantastic honor to sit here with Dr. Leila Agrawal today, and she will talk to us about all of the evidence, the studies, the trials that have been done up to date of the use of hormone replacement therapy for breast cancer patients. So without any further ado, let's welcome Dr. Agrawal onto the show. Right, Leila, I'm very excited that we are back here together and that you've given us your time and your clever brain to talk about the use of HRT after breast cancer. How are you today?
Good. Thank you so much for having me back. It's always a pleasure to talk to you, Danny.
Thank you. And I really am very grateful that you are happy to engage in this conversation with us. We just had a little bit of a chat before we press record. It's a very emotive conversation. There are lots of conflicting opinions out there on the internet. But actually, like with anything, we have facts. There are studies we can look at, and I want to look at those with you today, and really looking at the use of hormones, so systemic hormone replacement therapy for someone that's had a breast cancer diagnosis, and to look at the nitty-gritty, different trials, different people, and for you to also tell us what was good about these studies, what was bad about these studies. But before we do so, I feel I'd love a little bit of a few minutes of an explanation from you about how drugs like tamoxifen and aromatase inhibitors work, how breast cancer treatments work, before we talk about HRT, just so we're all clear about that. Is that okay?
Yeah, absolutely. So I'll start off by, as most of your listeners know, breast cancer has different types of breast cancer receptors. So when someone's diagnosed with breast cancer, one of the important pieces of information that comes after is what is the receptor status. And when we talk about that, we're really talking about three different receptors. Two of them are hormone receptors: estrogen receptor and progesterone receptor. And so when somebody has a positive value for the estrogen receptor, progesterone receptor, it's often termed as a hormone receptor positive breast cancer. It's also sometimes called a hormone sensitive cancer. And, that's a really important piece of information. The third receptor is called HER2 or HER2, and that can be positive or negative, irrespective of the estrogen receptor status too. So some people might have a cancer that's called a triple positive breast cancer or a triple negative breast cancer, or other varieties. So, when we're talking about breast cancer and the effect of hormones on breast cancer, it's really important to understand that there's going to be a distinction with these different tumor types. So for people who are diagnosed with a hormone receptor positive breast cancer, most of the time, typically a form of endocrine therapy, which is a type of treatment that acts on the hormones, is offered as part of the treatment plan. And one of those medications is called tamoxifen, and that is a category of medication called a selective estrogen receptor modulator. So in essence, it has an action to block estrogen in some tissues, and it actually acts as a weak estrogen in other tissues. So that's tamoxifen, and that's often offered to women who are premenopausal, and it is also effective in women who are postmenopausal. So tamoxifen works both in pre and postmenopausal women. The other medication category that's commonly used is called aromatase inhibitors. And aromatase inhibitors work in a different way. They actually lower the body's conversion of a precursor to estrogen into estrogen. So that medication blocks that step. And as a result, the circulating levels of estrogen drop to a lower level. And it's not necessarily to measure that. That's not something we do. We don't need to know what that value is. And those medications, aromatase inhibitors, they include letrozole, anastrozole, and exemestane, and they are used in postmenopausal women. Also, they can be used in premenopausal women, but in that case, it needs to be done in conjunction with a method to either suppress or stop ovarian function. So if somebody is premenopausal, they might be on shots to temporarily suppress their ovary function and take an aromatase inhibitor. So that's just sort of the general background on how we're going to be talking today about the different types of breast cancer and these medications that many people might be on and how they work.
And often women think that tamoxifen puts them into the menopause, but it doesn't.
Mm-hmm.
But does it make people feel as if they're in the menopause? Is that why maybe there is a link?
Mm-hmm. That's exactly right. So tamoxifen doesn't cause menopause, but it might cause someone to feel the symptoms that are associated with menopause. For example, some of the side effects are going to be hot flashes, night sweats, achy joints, might affect mood or, foggy thinking, sexual health, which we talked about previously, vaginal dryness, vulvar dryness, sometimes discharge, libido, all of those things that are associated with menopausal symptoms are also potential side effects of tamoxifen.
And we know that for many women, not all, but many women, these side effects of aromatase inhibitors can be quite severe, so much so that only half or about 60% of people actually finish their treatment by the time 5 years is up. So many women feel they can't sustain their treatments because of side effects. So what would these side effects be? Are they similar to tamoxifen?
Yes, so the aromatase inhibitors, they also carry these menopausal side effects, and really both of them can cause the same, or overlapping side effects, but each individual person might feel different on one versus another. So the aromatase inhibitors also can cause side effects like hot flashes, night sweats, arthralgias and myalgias, so achy joints, achy muscles. They tend to be more severe on the sexual health changes like the vulvovaginal dryness, the symptoms of genitourinary syndrome of menopause, and then they also have detrimental impact on the bone density as well.
And then it kind of makes sense with the whole menopause conversation out there being flourishing and having flourished over the last few years, that women might think HRT might help me. I've got all these menopausal symptoms. HRT might help me. And of course, it's important to think, when might someone have that question? So some people might be younger when they're diagnosed and then going through perimenopause again. And so maybe 15 years after a cancer diagnosis, they might be thinking, maybe HRT is a good idea for me now. I've got all of these symptoms. It kind of makes sense that the question is there, doesn't it?
For sure. Yeah, I think that's a very natural question that people might have.
Yeah. And so we have answers to what happens when you give those hormones back, and you've summed them up really beautifully on your social media. And I'd love for us to go through them and to really take the time and sum them up and talk about the benefits and what hasn't gone so well with these studies. Shall we talk about when the first one happened? And let's talk about the first one if you can.
Yeah, so we can even back up further than that to, the 90s, early 2000s. There were a number of mostly observational or retrospective studies published. There was a very high, relative to current times, utilization of hormone replacement therapy at that time. And, so these studies were published looking at not a prospective randomized trial, so not going forward and making sure that the groups were as equal as possible, but just looking at people who used hormone replacement therapy versus those who didn't after a diagnosis of breast cancer. And many of these studies showed no increased risk of recurrence or mortality in the people who used hormone replacement therapy. So that sort of set the stage for starting a randomized control trial where this could be really evaluated in a more rigorous manner. The trouble with observational or retrospective studies is that people are not, they don't come into the trial and say half of you are going to be doing hormone replacement therapy, the other half are not. And then we're going to make sure that the groups are as balanced as we can in terms of stage and other health issues and age and, all these other factors that could play a role. It is simply who chose to use it versus who chose not to use it. And because of that fact, all retrospective or observational trials are open to something called bias, meaning that the people who chose to use hormone replacement therapy may not have had the same underlying risk or underlying, lifestyle or underlying socioeconomic factors compared to the people who didn't use it. And so that means that, we have to consider that when looking at those trials. So I think that's of course a big downside of observational trials. And I will say both prospective, meaning you're starting out and you're doing an intervention and following things forward over time, as well as observational trials or retrospective, where we say, okay, let's look back and see over the past 10 years what happened to these people. These are both important types of trials that we get important information from, but they're different and they have different concerns that we have to look at. So, at that point, the decision was made to start these prospective randomized trials. So the first one was called Habits, and it was kind of started around the same time as another trial called the Stockholm Study. So we can kind of go over those next if you'd like to.
And when did that happen, Leila? So we're now in 2024. For anyone watching this back in years to come, when were these studies initiated?
So these were started in the early 2000s.
Okay, and the first one was the Habits study. And who were the people, the women that went into this study? Do we know much about them?
Yeah, so these are people who had breast cancer diagnosis. They were a varying time frame since their diagnosis. Some of them were using medications like tamoxifen or even aromatase inhibitors at the time. And randomized trials, when they're done, they have safety features built in, meaning that if the trial showed that the intervention or the experimental arm was for some reason more dangerous to patients than the control arm, then these safety features are built in to stop the trial early to protect the participants. And what happened was the Habits trial was started, and about 2 years into the trial in 2003, they determined that there was an increased risk of recurrence noted in the people who were assigned or randomized to use hormone replacement therapy. And because this was seen, the decision was made to stop the trial early or to discontinue it early, meaning that they didn't continue to enroll patients to reach the size of the study that they had intended in order to get the full statistical power to really make firm conclusions. So at that time, they found that out of 434 patients, there were 26 recurrences in the HRT group and 7 cases in the non-HRT group. So those are the absolute numbers. And then they also tell you a hazard ratio, or how much more likely is that to happen. So what that meant was at that time point, the hormone replacement therapy users were 3.3 times more likely to experience, or the hazard ratio was 3.3. So they were more likely to have the recurrence. So they also provided information about the types of recurrences that were detected, and most of these were either local recurrence, meaning cancer came back in the same breast, or contralateral cancers. But there were 10 that had distant metastatic disease who used hormone replacement therapy compared to 5 who didn't. So when these numbers are so small, statistically, it's hard to draw conclusions, but they had to stop it at that point because they noticed an increased risk of cancer recurrence with the hormone replacement therapy users.
Before you go on, Leila, because as a patient, the number of people in a trial doesn't mean anything to me. So you're sort of saying there were 400 women in this Habits trial. In other drug trials, is it like 4,000 or 40,000, or is is 400 a small number? How does it compare?
Yeah, so it's going to be different for every trial, but usually before a trial is started, the investigators of the trial have to estimate some statistical facts. So they have to basically say, okay, how many recurrences do we predict would happen anyway in this group of people? And then they had to say, we want to make sure that it's not more than some amount above that. So for example, they would say, if we want to be able to figure out that it's not 5% worse, how many people do we need in the study to determine that? So I don't have the exact number, but I believe they were aiming for, at least 3 times that many patients roughly. So it was stopped much sooner than the intended number of participants. And this happens, in other trials and, in other situations as well, for the reason of safety. And we're always left at the end of the day then wondering, well, what would the results have shown if we had the full amount? Would we be able to draw more reliable conclusions?
Mm. And of course, because they had mixed people in there, right? Some people on aromatase inhibitors, some people on tamoxifen, they probably already had different risks of a recurrence. You're saying it's a small number of people. It's an old kind of study. What type of HRT were they getting? Were they all getting the same HRT?
Yes. So, the type of HRT that was used at that point in time is different than the formulations that are available today. So there was more use of synthetic hormones, different than what is typically prescribed nowadays. So the type of hormone was different as well.
Okay.
So this study then, that was the result at 2 years. So then they continued to watch what happened after that, although everyone was taken off their HRT per the protocol, and they sort of observed what happened over time. So at the 5-year mark, the numbers that they reported were 39 recurrences in the HRT group and 17 in the control arm. So in percentages, that meant 22% of the HRT users had a recurrence compared to 8% in the non-users. And at that time point, they said it was 2.4 times more likely to have a recurrence in the HRT group compared to the control group.
And of course, as a patient, no one wants a cancer recurrence. No one wants their cancer to come back. How does the recurrence translate to mortality, though? Because I know it's a little bit different, isn't it? Some people might really just be worried that you're just going to pass away from your cancer, and other people might think a recurrence will lead to a mortality. Like, is there a difference between recurrence and mortality, or did they not look at that? Or
yeah, so a recurrence means that the cancer has come back. And they did specify, did it come back in the breast? If that's the case, then still potentially more treatments, including sometimes surgery, sometimes radiation, sometimes chemo or more hormone blockers, whatever is appropriate for that case, may be done. And that person may then go on to either never have a cancer recurrence again, or they may go on to have another recurrence or a metastatic recurrence. The other type of recurrence that they noted is called distant. So distant means metastatic. So distant means it came back somewhere else, not in the breast, but potentially bone or another organ. And that is metastatic, which, as we know, is treatable, but is not curable. So the type of recurrence is important. So this particular, the time points that I mentioned, they did not see any differences in mortality, meaning the same, the same amount of people were alive in both arms. So the deaths from breast cancer were not different at that time point.
Okay. So then at the same time, there was another study, the Stockholm Study. And did they look, why would they look at the same kind of thing, HRT after breast cancer, when the HABIT study was already running? Like, what was their point of difference? Like, why would they even bother?
Well, I think that they had somehow at some point planned to also put the data together, maybe have more patients involved in the study and so forth. So it is something that is done. Even more modern trials have done similar things where different trials will be going and then looking at similar questions with the thought to kind of combine them at some point potentially. But of course, each trial had different patients in their trials. So the people who were in the trial were different, the risk was different, the types of hormones used were different, so they were not exactly the same protocols by any means. So the other trial was called the Stockholm Study, and they had a similar intervention, but again, as I mentioned, there were differences between the trials. And when the habits trial closed, the investigators of the Stockholm Study, they had to decide what to do. And they had thought about this ahead of time, is my understanding, and they had written in the protocol that they would not be mandated to stop if the other trials did stop early, but they were considering, I'm sure, lots of factors, including, well, if this other study just showed harm, increased recurrences, what is ethically the right thing to do? And also, they might have been thinking, can we continue to enroll patients on this study? When we're telling them about it, we say, oh, but this other study showed increased recurrences and they had to shut it down. So I'm sure a lot of thought hopefully went into that decision, but they elected to also close the trial at that time. And so when the habits trial stopped, the Stockholm Study also closed. And at that time, different than the habits, the Stockholm Study did not show an increased risk of cancer recurrence. So they had accrued about 379 patients at that time, and they did not see increased cancer risk. And they actually ended up following the patients in that study and reported 10-year data. But keep in mind, they were probably only exposed to the hormone therapy on study for maybe about 2 years or so. And at the extended 10-year follow-up, they showed no significant difference in breast cancer events. And the numbers there, the hormone replacement therapy user group had 60 events compared to 48 in the non-user. So even though that number is higher and the hazard ratio is 1.3, meaning that number means 30% higher, but it is not statistically significant. So when we look at that data, the way that's interpreted is there was no statistically significant difference. But keep in mind, again, because it was closed early, they didn't have enough patients in that trial to even be able to have significance with those numbers. So when trials close early, they are limited. We just cannot get more information out of it than what there is. So, there's a good and a bad side to making the decision to close the trial.
Yeah. I mean, what have they done better? Because they've not shown an increased risk of recurrence. What's the difference? There must be a difference then, or is this just how medicine and trials and evidence works, and you get X result from one and Y result from the other? Or was there a difference?
Well, there were differences, and so some of the differences had to do with the patients. So the patients may have had a overall lower risk profile, meaning some of the features that are associated with the risk, like nodes or the size of the tumor or things like that, at that point were lower risk. And of course, some of that just depends on who enrolled in the trial, as well as how protocols are written to say who is, included and who is not in the trial. The other thing is they used a different form of hormones compared to the habits trial. The habits trial hormones that were used had more progesterone in it. So that was a difference there. And then also the Stockholm Study had more patients that were using tamoxifen at the same time. And, as we talked about at the beginning, tamoxifen has the effect in some tissue of blocking or counteracting the effect of hormones. And so that potentially might have played a role there. We don't know the answers to those questions, but those were some of the differences that might account for why the habits trial and the Stockholm trial had different results at that time.
And then it didn't stop there. So people wanted to know more. I mean, of course, I understand the trials were stopped early, because if any of my relatives were in one of those trials, you would say, stop it immediately, right? You would never want anyone to come to any harm. And now looking back, I wonder whether a lot of doctors think, oh my gosh, it would be really good to know if the trials had run for the amount of time. But anyway, what happened next? What happened? This is like a saga.
Yeah, it really is a saga
really
that has
is.
not ended yet, hopefully. But
No.
there was another trial that was called Liberate. So this trial is, I would say, different than the others because it uses a different hormone. So the hormone that was used in this trial is called tibolone. And this is one that we do not have available in the United States. But my understanding, it is still used in Europe. So I don't know if you've talked to people who are on tibolone, or if this is something that's still used, but it's a different hormone and it has different properties, and it is not the same as the hormones that were used in Habits in Stockholm, and it is not at all the same as the hormones that are used today. But I still think this trial is relevant because at the time they thought that it was a good candidate for doing this trial, and they did a large and relatively well-run study using this agent because they suspected that maybe it was going to be an acceptable option for HRT after breast cancer. And I think, this really underscores the fact that even if we think something is promising, doing the trial and actually knowing the answer is so important. And here we saw that, again, there was an increased risk of recurrence in the people assigned to use tibolone. And so after 3.1 years, they had 3,000 patients enrolled. So this is a much larger study than even the two other studies combined. And they found an overall risk of recurrence in the users of tibolone, and the hazard ratio was 1.4, meaning 40% more likely. And the statistics on that were 15% on tibolone had a cancer recurrence and 10.7% on the placebo. And here we saw that most of the recurrences were actually distant or metastatic recurrences here. So, again, it is not the same hormone as what is used today, but I think that it is important to understand that this trial was done and where it fits in with our understanding about HRT and hormones after a breast cancer diagnosis. So clearly the conclusion of this is very clear, is that tibolone should not be used after a breast cancer diagnosis, and that it did show significantly to increase cancer recurrence risk.
Well, that's helpful because at least you can rule the one out. With this then, so you then looking at 600, 700 women from the first two trials, another 3,000 from this trial. We're still looking at very few women. If I think, I don't know, by 2050, there'll be millions of female cancer survivors that are now living with 5 years and beyond. It is astonishing that no one has come up with a better idea of how to help, right? I mean, yeah, because these are small numbers really in comparison to the millions that are suffering. But I'm not going to put the world right now. What happened and what
I think you will eventually, Danny. I'm confident you will.
What do we do with this data? So when you talked about the observational studies that haven't shown an increased risk of recurrence, then you talk about randomized controlled trials. We've mentioned 3 different ones. It's a bit frustrating as a patient to think, wow, it's information out there, but it's a little bit conflicting. So what do you do as doctors, or what do you do as medical societies with different results?
Mm-hmm. So sometimes what's done is another type of a study called a meta-analysis. So a meta-analysis takes these different trials, sometimes many different trials, and tries to lump the results together to get larger numbers to hopefully draw better conclusions. And, the good thing about a meta-analysis is that it increases the number of patients that are in the study. The bad thing about it is it's only as good as the trials that go into it. And when the trials that go into it are very different from one another, like, for example, using totally different hormones, then again, the conclusions are limited. So there was a meta-analysis done, but again, it's only as good as the data that goes into it, which, as we've talked about, that data has a lot of limitations due to the fact that the trials were closed early. They had very different inclusion criteria. It was all across the board there. So in 2021, a systematic review and meta-analysis was published, and that include 4 randomized trials, the 3 that we just talked about and an additional one. And what they found was that HRT increased the risk of breast cancer recurrence compared to placebo overall. And that's likely driven by the results of the Liberate trial, because that was the largest number of patients in that group. So here overall, they found the hazard ratio was 1.46. And then when they divided it up between the patients who had hormone receptor positive versus hormone receptor negative, which so far we've just been talking about everybody as a whole, what they found was for hormone receptor positive in this meta-analysis, the hazard ratio was 1.8, meaning that patients who had hormone receptor positive breast cancer, out of those patients, were 80% more likely to have that recurrence. But those with hormone receptor negative did not have an increased recurrence in this meta-analysis. So,
Leila,
that's what that showed.
Can we talk about those numbers again? So 1.8 and 80%. Can you explain that for me a little bit more? Like, what does that mean? So say after I've had a breast cancer diagnosis, I would always have a rest, even after all of your amazing treatment, I will always have a risk to have a recurrence, right? And that is different for all of us, right? So my risk of a cancer recurrence might be different to that of all of the women in my community, because we've all had different cancers, different treatments. What does the 1.8% then do? So if I have a 1.8%
Yeah, so thank you for
higher...
stopping me there. That's a really great point, because, when we talk about these numbers and we throw out these different like percentages and this time's more likely and all this, it can be really, sort of confusing. Like, what are you talking about? Those are different numbers than what somebody else told me. So that doesn't mean that people had an 80% risk of recurrence. That's not what it means. What it means is, compared to the group that didn't have it, that's how much they were that much more likely to have a recurrence. So for example, if somebody had a 10% risk of cancer recurrence and we told them that they were going to be 50% more likely to have a recurrence, it would go to 15%. So that's a total absolute amount, which is 5% difference. So, I think it's a really good point that you're bringing up here is, what is the risk to begin with, and then how much does it go down with a treatment, or how much would it go up? So if that risk is lower to begin with, even if it's cut in half, you're changing it this much. Whereas if that risk is higher to begin with and you cut it in half, you're bringing it down that much. I think it's very important that when people are talking to their doctors about their risk, it's important to understand, okay, what do those numbers mean exactly? Because sometimes we talk about something which is called an absolute risk. So that's the number, that's the percentage that the risk is. And other times we talk about a relative risk, which is how much it could reduce it. So for example, if I told someone, for example, this treatment can cut the risk down by half, that doesn't mean they had 100% risk and now they have a 50% risk. Whatever that underlying risk is, if it's relatively smaller and it cuts it down in half, it'll be this much of an impact. Where if it's relatively larger and it cuts it down in half, it'll be a larger absolute difference.
That makes a lot of sense, because for many, many years, when I heard there is a 50% chance of a recurrence, I always thought, well, that's 1 in 2. It's like half. You either get it or you don't get it. And often I always forgot to really think, well, where am I starting? Where is my starting point? And then we can add these numbers, isn't it? And numbers are really confusing. 1.8% is so different to 80%. And it's really important to really ask for someone to help interpret those numbers when we talk about data, like you've explained to us.
Absolutely. And there's so many different ways that people might like to hear that information, or it might be better to get that information. So one way that can be done is with the type of a chart that shows 100 figures of people. And so information can be presented in this way, And it'll say, okay, if there were 100 people just like you, without the treatment, this many people, and it will show them in a certain color, would have a recurrence, and the rest wouldn't. And with the treatment, it'll show a fewer number of people will have recurrence. But a lot of people wouldn't have had recurrence anyway, and some people will have recurrence anyway. So it's really the difference, which is the impact of the treatment. So, sometimes we do have access to certain tools that can help us print out, not in all cases, but print out a sheet like that, which will show, okay, this is, 100 figures, recurrence without treatment, recurrence with treatment. So that can be a visual tool that may be useful.
And then you can add, and what if I put HRT back into the mix? In the worst case scenario, you can change that chart again, isn't it? Then it would be
right.
very visible for someone.
Exactly. That's sort of an estimation, that is less, definitive, but it can be used. Yes.
Yeah. So I think there will be a lot of people now thinking, okay, I'm on tamoxifen, and other people think I'm on aromatase inhibitors. There'll be other people saying, but I'm the triple negative patient. What difference? So the meta-analysis you were explaining, what difference does that mean to people on different treatments? Or is it because the data is really old and really bad, and with very few people, that we actually can't translate it into real? How do we work that data into people now?
Well, I think the most useful way to look at that is to look at the hormone receptor positive or hormone receptor negative cancer. Okay. So the meta-analysis, which reported on the studies that they included, showed an increased risk in people who had hormone receptor positive breast cancer who were assigned to the hormone therapy group in those studies. But for people who had hormone receptor negative, there was no increase in recurrence. So I think that's a very useful piece of information from that meta-analysis.
Why do so many people who have had a triple negative breast cancer don't get access to HRT? Is there something people say it can come back as the other cancer, or what is there? Because there are so many people that say, I've had triple negative, my oncologist will absolutely say no. But given the data you've just explained, where would that come from?
So it probably comes from the fact that we know that breast cancers are not completely the same in every single cell. There's something called heterogeneity, meaning that different cells in the cancer are different. And even if we see hormone receptor negative, there is always that possibility that some of those cancer cells still had hormone receptor positivity. And the other thing that we know that we're learning more about is that estrogen and progesterone are not the only relevant hormone receptors on breast cancer. There's also something called androgen receptors, and that is, another hormone receptor. And there's even treatments that target that androgen receptor that are being studied. So this is not a standard thing, but we do know that many breast cancers will express androgen receptors too. We just don't know everything about what that means. And some cancers that are triple negative may have androgen receptors on them as well. And when we're introducing additional hormones into the system, could that somehow lead to conversion and stimulation of an androgen receptor? So these are more on the level of, concerns about, is it absolutely 100% safe? We don't know that for sure. And that these are some of the mechanisms we're learning more about that introduce, these questions. So I think that is why perhaps many oncologists will advise against the use of hormone replacement therapy, even for patients who have a triple negative or a hormone receptor negative, because when we say hormone receptor negative, they're not checking for the androgen receptor. That's not a standard thing that we check for.
So are we waiting for yet another randomized control trial for that? I guess that's what we need, right?
Well, we need a lot. We need
Yeah.
a lot more updated information, with what we've learned over all these years. And of course, these trials are not really the only reason that it's recommended um, to avoid hormone replacement therapy after a hormone receptor positive breast cancer. As your listeners who have been diagnosed with this know, there's no all clear signal at the 5-year mark. There is an ongoing risk of what is called a later recurrence, and even tumors of the smaller stages will still have that potential risk, and we see that more with hormone receptor positive. And so what that means is we know that there are still potential cancer cells there because we see people have recurrences after that fact. And I think, we do need a lot more research, but at the same time, there's also been other advances that hopefully would allow us to take a little more sophisticated look at this. For example, they are studying, still not standard of care by any means, but tests that look at circulating tumor cells in the blood that are correlated with risk of recurrence. We also have genomic profile testing that can be done. For example, a breast cancer index that gives a prediction of late recurrence. So, those tools have also been developed. And, I think that it would be interesting to see, specific to the question of hormone replacement therapy or menopause hormone therapy, if that would be incorporated into clinical trial design. For example, in many areas of breast cancer where they're trying to pull back on treatments safely, so be able to safely omit certain treatments. For example, not everybody gets radiation after a lumpectomy anymore. And that
Yeah.
has been done by pulling back and doing very specific studies over time to determine, can we omit radiation in this group of people? Can we omit? And then now that's starting to increase. So first it was people over age 70, then over age 65 with certain features. Now we're getting data for age 55. So, we do have a pattern of where we have looked at selected populations that might have a lower risk for whatever reason, and kind of looked at some of these interventions. I do think there's a precedent for how this could be done.
Yeah. And it's positive to think that way, isn't it? And especially if you're the patient, you think, oh gosh, we need so much more. Talk to me about the tamoxifen side of things again, because there are so many women who are on tamoxifen who have the side effects, who then say, but if it blocks the estrogen conversion in the breast, the tamoxifen, then surely if I put a little bit of HRT back in, it would still block that estrogen production in the breast. But we don't have any data that isn't the case, right? That's what, yeah.
Yeah, well, I mean, I think that's a very interesting question. And, um, I think that the data that we have so far, which of course is already limited, then when you divide it into the tamoxifen users versus aromatase, it's even more limited. We still see conflicting information coming out about that. So I don't believe, in my
Yeah.
opinion, that the data shows that this is definitely a clearly safer thing to do. But
Yeah.
and there's other formulations that are coming out that have a combination of estrogen combined with a medication in a similar category to tamoxifen, which is a form of a mixed blocker that's incorporated in the HRT. And so, that's another very interesting medication for this group, but it has not been studied in breast cancer survivors, and it has not shown that it is safe. So similar to the tibolone, while it seems really promising, we really need the actual studies to be done. But between when all this happened in the early 2000s and now, there have been a lot of changes in how we treat breast cancer, how we treat menopause. Things are very different than they were at that time.
Thank you, Leila. That has been fabulous, fabulous. I think you have answered all of my questions, and I'm hoping that everyone who has listened, I've been able to ask their questions for them. I know it doesn't work like that, but I have a whole list of questions, and you've gone through all of them. Thank you so much for your time again today.
Thank you so much, Danny.
Right. I hope this conversation with Dr. Leila Agrawal has been very helpful and useful for you. It might be a bit frustrating for you to realize what the information is, the evidence is that we have for the use of hormone replacement therapy for those affected by breast cancer. It's upsetting and frustrating to know that the evidence we have is so old, uses preparations that aren't used today, that they're studies have been done on a very small group of women, and it doesn't feel like enough has been done. So that's always the feeling I have when I discuss the evidence of HRT after breast cancer with doctors and with patients alike. So you might have a whole mixed bag of emotions, and I want to really sort of say to you, please honor all of the emotions you have. We're talking about something that is really difficult. We're talking about how to move forward from breast cancer. We're talking about risks and benefits. And this might open and bring upon lots of different feelings for you. And sometimes it's good to honor those feelings. So if you think the conversation we have just had makes you feel uncomfortable, maybe this isn't the right time for you to explore more. You can always come back to the HRT After Breast Cancer series at a later stage. It'll always be there for you. And so really honor your feelings. I'm going to link to Dr. Leila Agrawal's Instagram post in the show notes. She's a brilliant educator on social media. So if you want to follow someone who is going to give you evidence-based, sound advice, then do follow Leila. On our next episode, I'm going to bring on Professor Richard Simcock. He's also a consultant clinical oncologist, and I want to talk to him about risk. What is the risk we're talking about, and what does it mean for us as patients? How can we quantify that risk? I also want to know from him who holds the risk. Is it the patient? Is it the doctor? Is it both of them together? And I want to know from him, how do we move forward now with the evidence and the information that we have? And so please do join me on our next episode. I can't wait to have this conversation and to keep exploring this topic with all of you.